Can I introduce our first speaker, Dr. David Allsup. David Allsup is a senior lecturer in hematology at the Hull York Medical School and honorary NHS consultant in hematology at the Hull University Teaching Hospital Trust. He is a member of the CLL trial subgroup and co-investigator on the FLAIR clinical trial, which many of our members will be very much aware of. And he is developing a phase 3 clinical trial for relapsed CLL. David, can I hand over to you, please?
So, thank you for asking me to talk. As you say, I'm David Allsup. I'm a senior lecturer in the Hull York Medical School, but mostly I'm a jobbing consultant hematologist in the Hull hospitals, where I've worked for quite a while. And I've got a very long-standing interest in CLL that dates back to when I was more junior, and I did my PhD in CLL around 2000. And my PhD was looking at investigating some aspects of CLL that help lay the ground for ibrutinib and other treatments that are used. And I thought I'd talk a little bit about clinical aspects of CLL that are relevant to the paper that Brian mentioned. And in particular, the perennial problem of how can we know who with CLL is going to go and need treatment in the future? This idea of prognostication. And so that leads to the title of my talk, really. CLL, can we predict the risk of progression, and do we want to? Is it a good idea? So this is what we're talking about. So as a hematologist, my job is to look after people clinically, but I also work in the labs and the pathology labs. So when people like myself think of CLL, this is often what pops into our mind. So hematologists, by and large, love pictures of blood cells and love pictures of sort of purple blobs. And this is what we see when we look down the microscope at a blood sample from somebody with CLL. So often a blood sample will come in from a GP practice and it'll get flagged up by my colleagues in the laboratory as having a high white count. And then some of the blood will be put onto a glass slide and smeared out very thin and stained with something to make the cells visible. And then I look down the microscope and this is what I see. And what I see is lots of these blobs here, which are red blood cells. When these are low, that causes anemia. And these are white blood cells, and these are the CLL cells that we see, and it's a very characteristic appearance. And these are cells that have sort of smashed or broken open during the process of making the blood film. And there's something about CLL cells that predispose them to breaking apart on the glass slide, and we call these smear cells. So this is very suggestive of CLL. And then to confirm the diagnosis, the blood will get sent off to a specialist laboratory. So we use a laboratory in Leeds called HMDS. And Leeds would look at these cells, and they'd look at what elements are expressed on the surface of the cells. And there's a characteristic pattern of things that are found on the surface of these cells that can then indicate a diagnosis of CLL. So the vast majority of CLL, certainly in my practice in Hull, is diagnosed when somebody goes along for a checkup, a routine blood test, the GP's being conscientious and seeing somebody with diabetes or blood pressure or something, and does a routine blood count or a well person checkup. And so locally in Hull, about 80% of our cases of CLL are diagnosed this way. And I'll get a letter, please see this person who's had a high white count and who's got CLL. Some people, however, do come to us because they've presented to the GP, usually with symptoms. And the symptoms, I'm sure many people listening to this will know, can sometimes be very, very insidious and non-descriptive. It's sort of, more tired, less good, stop doing things they enjoy. I don't know, maybe stop walking as far with the dog, don't go in the garden as much, stop maybe having problems at work because of low energy levels, sort of progressive tiredness. The problem with tiredness as a symptom is tiredness can be due to a whole host of other conditions. It's a very non-specific thing. And then some people have sweats, which can sometimes be drenching. But again, it's very hard to know how much sweats are due to the disease and how much it's due to other problems. Sometimes people come to us because they've noticed lumps in the neck, swollen lump. Some people, sometimes it's other people around them commenting that the neck looks a bit bigger, the shirt. Well, not many people do buttons up on shirts now, I suppose, but trouble doing up the buttons on shirts. And these lumps are often painless. Sometimes we'll explain weight loss is an issue, and again, this is sometimes noted by people around the individual. People comment that look a bit more gaunt. Yes, and some people present with an infection, so sometimes someone will present to the hospital with a pneumonia or something like that, and they're found to have CLL, and sometimes people have abnormal bruising, the platelet count's low. So people can present with a whole variety of symptoms, but most commonly is picked up incidentally. And then when we meet somebody, we explain the diagnosis and what it means and the implications. But then as part of the assessment, we try and get a feel for, is this person's CLL going to be stable, or is it one that's going to move forward and need treatment? And one way we do that is by doing an assessment called the Binay assessment or the RI assessment. And we like this because it's fairly straightforward. So in the Binay assessment, if you're not anemic, so this is saying that you're basically not anemic, and something called the platelet count is more or less normal, and you don't have many areas of swollen lymph glands, then that will be viewed as early stage disease and more likely to have a nice stable indolent course. Conversely, if when we meet the person for the first time, they're anemic, so the low red cells, and that would make you feel tired, or your platelets are low, so that might cause bruising. Then that indicates that the CLL is basically pushing out healthy elements of the bone marrow and is causing problems and is likely to need therapy. So in terms of once you've been diagnosed with CLL, what does that mean? What does that mean for the future? Which is, and one way to look at that is to look at large numbers of people who are diagnosed with CLL. So in Yorkshire and Humberside, where I work, there's a process whereby all people who are diagnosed with all blood cancers, their data is recorded as part of the process and with consent. And then people are followed. So all this is people who are diagnosed in primary care by GPs and by people like me. And so everybody, it captures everything. And then the outcomes and what subsequently happens is followed. So when you look at absolutely everybody, what you see is this graph is sort of saying what the outcomes are with people who are newly diagnosed. And what this is saying, first of all, is that the outcomes for CLL are very good. And part of that is that a lot of people are asymptomatic and don't need treatment, but I think also reflects how our therapies have come on and improved. And this top line here is saying that if you're under the age of 60, your survival is very close to that of people of a similar age who don't have CLL. And this line down here is saying if you're over the age of 80, well, your outcomes are still very good, but maybe not quite as good as someone that doesn't have CLL. And that's probably because of the impact of other health problems that you can acquire as you get a bit older on your CLL and your response to treatment. And this other graph down here, it's looking at sort of the same sort of information. So it's information from people all across Yorkshire over a really quite prolonged period of time. And it's saying that for Binay stage A people, their outcomes are very close to that of the population who don't have CLL. And for stage C disease, these outcomes are down a little bit. But again, very good compared to the survival of the general population, which again is a reflection of how far I think we've all come in terms of CLL treatment. So when do we treat? So we meet somebody with newly diagnosed CLL and explain the diagnosis and tell them they've got and then the next breath we watch you and monitor you, which is often sort of a counterintuitive thing. You know, we've diagnosed you with a blood cancer, why aren't we treating you? And the reason for that is we know a lot of people with early stage disease do very, very well. So the people who we would think about treatment in are people who have stage A disease, but who the white count is going up and up and up and up fairly quickly. Or people who have stage C disease, where we know the leukemia is affecting the normal functioning of the bone marrow. People who've got you know, lymph nodes that are getting bigger and are uncomfortable, you know, it would seem silly not to offer treatment for them. People who is uncomfortable, such as drenching quality of life. And the sort of treatment we would offer, well, this is changing very, very rapidly in the UK, which again is good. It's a sign that we've got new treatments coming through and that the NHS is facing up to the reality of funding them for people. So right now, the options are venetoclax and obinutuzumab. So venetoclax is a tablet-based treatment that targets the leukemia cells in quite a specific way, and obinutuzumab is an infusion of an antibody that sensitizes the leukemia cells to the venetoclax. There's a tablet called acalabrutinib that's been recently approved. There's chemotherapy, which is rapidly falling out of favour, though maybe a role in some circumstances for some people. And there's always clinical trials. So the FLAIR clinical trial that was mentioned at the start of this, this is a big trial comparing newer treatments with ibrutinib or ibrutinib venetoclax with chemo. The FLAIR trial was done exceptionally well in the UK, thanks to people listening to this presentation agreeing to be treated within it. And it's now, I think, it's the largest clinical trial looking at CLL in the world. So the main part of the trial is closed, but there's still a subset of there's still a part of the trial open for certain people with high-risk disease. So when shouldn't we be offering treatment for CLL? So again, in 2021, offering treatment for somebody with stable, asymptomatic, non-progressive disease probably isn't the right thing to do at the moment. But is there a role for trying to think, well, who might need treatment in the future? You know, are there people who maybe are at higher risk of progression, who maybe we should keep a closer eye on, and how would we deal with that? And what's the role for people who may be at higher risk of progression with the watch and wait strategy? And again, I think, as Brian said, that, you know, is it watch and wait? That's what we medics call it, but you know, could it be watch and worry? Sitting there worrying, is it useful to know that you or a person may be more likely to need treatment in the future? So there's really a sort of a small industry with people like Prof. Allan and myself trying to identify markers of progression, try to identify who of those people who initially don't need treatment will ultimately go on to need therapy. And initially, there's fairly basic things like your white cell count. So if you have a very high white cell count when you first meet someone like me, you're more likely to wind up needing treatment than if your white cell count is only just increased above normal. The Binay stage I've mentioned. Age, if you're a bit older, you're more likely to wind up needing treatment. There's genetic analyses are done. Oh, sorry. So we can look at the chromosomes, which is the sort of packages that hold genetic material inside the leukemia cells, and there's certain abnormalities within those chromosomes. Sometimes the chromosomes have got bits missing or extra bits that can indicate a good or a less good prognosis. And then science has moved on, and it's possible now for people like Prof. Allan to read the entire genetic code and do all sorts of fancy things like that. And those sort of methods can pick up abnormalities in certain genes, which are genes of this sort of instruction kit that tells the body how to make things. And so if you've got an abnormality in something that's important for keeping a cell alive, that can sometimes have a good or an adverse prognosis. And then the other thing that can be done is the laboratories like the one in Leeds can take the leukemia cells and they can look at what's stuck on the surface of leukemia cells. There's things called antigens, which are basically bits of proteins that stick as a view to have prognostic significance. And then there's something else called the IGVH assessment, which again, it looks at what sort of cell the leukemia cell might have been before it turned leukemic, and that can give you an idea as to prognosis. And measuring things in the blood, levels of something called thymidine kinase and beta-2 microglobulin can also be prognostic. So those things are all looked at, tend to be in isolation, you know, high this or low that is good or bad or whatever. And to try and move beyond that, people have tried to incorporate multiple factors into one score. And so there's something called the CLL IPI that I think was devised by the German CLL group. And this really incorporates things that are robustly found to predict prognosis, such as age, Binay stage, this thing serum beta-2 microglobulin, IGVH mutation, and TP53. And then depending on what constellation of those you have, that means you're more or less likely to have disease that progresses. So if you're a little bit older, you've got stage C disease, a high beta-2 microglobulin, unmutated VH and mutated TP53, your risk of progression will be higher than if it's the counterpoint, if you're younger with stage A disease and so on. But this is only a guide. This can only say in very general terms, the person with the high score is more or less likely to progress, and it doesn't tell you when to treat. So it's an obvious question as to, well, if you can do all these fancy things and pull out a group of people who you think, well, this group of people it's a high risk of progression, why wait for them to progress and become poorly? Why not offer treatment sooner rather than later? And this question's been visited several times over the decades. Now, in the past, many decades ago, treatment was tried with a drug called chlorambucil, which is a sort of a tablet-based chemo thing, or fludarabine, which again is a tablet-based chemo. And giving people with asymptomatic CLL these drugs, well, you can make the blood counts look all nice. As far as I'm concerned, the white count comes down and that looks great. And maybe it takes longer for the disease to get to the point where you need treatment. Particularly this case earlier than they would need to, and you'll treat some people that would have never needed treatment. However, our therapies have moved on quite a lot now, and so there's a group have tried a treatment called lenalidomide, which is quite clever, and it sort of resets the immune system, and it's been shown that lenalidomide can sort of boost the immune responses in CLL, and giving lenalidomide to a group of patients with asymptomatic CLL, the idea was to try and boost the immune responses to vaccines. Now, that part didn't work, but it showed that the CLL would respond, and you had high response rates with not much toxicity. The German group used a more sophisticated way. They used sort of a scoring system using multiple different parameters, and then people identified at higher risk were given FCR, which again I'm sure some people listening to this have been on the receiving end of FCR. FCR is a very effective treatment, but it does have significant toxicities. And so giving high-risk asymptomatic people FCR, again, you can induce remissions, blood counts look normal, but there was some toxicity and it didn't ultimately affect survival. However, the treatments we have, so this treatment ibrutinib, which is a targeted therapy, more tolerable certainly than FCR. And there's a trial currently underway doing the same sort of thing, trying to identify high-risk people and treating early with ibrutinib. And the results of this hopefully will come out in the next few years. Certainly everyone's very excited about it. So going forward, really, sort of setting the scene for Prof. Allan a bit. So the question of, can we identify a group of high-risk asymptomatic patients who are all destined to progress? Can we identify them more effectively, especially now as our treatments are improving? And really what we're interested in is teasing out of this bit of the curve here, these group A patients, who of these people are destined to go on and progress and may, within a trial, benefit from preemptive therapy. So maybe this is a good approach, maybe, but only if our tests are good enough, only if we can reliably say that, and only really if our treatments are good enough. So that's all I have to say. Thank you.
David, thank you very much indeed for that talk. It's fascinating to see how things are developing and where we're getting to now.